people online, so that's great. Nice. Oops, I'm just gonna say got it here. I'm Sandeep Agarwal, for those that don't know me. And it's my pleasure to introduce Dr. Howlett. Don't call him Dr. Howlett, just call him Jonathan. So this is actually the first of a three-part series. So you'll get invited to the other two parts. You might have already received that information. The second one will be mostly on, it'll be on amyloidosis. And then the third one will be on treatment of HFpEF. So this particular presentation is on the diagnosis of HFpEF. And I'll quote one of my cardiology colleagues from a few years ago who said he didn't actually believe HFpEF existed. So it's kind of like, there was a time kind of like fibromyalgia where people didn't believe that it existed. And now people actually do believe it exists, and there's treatments and everything else. HFpEF, people didn't even believe it existed. And now it seems to be the most common thing we see. And one other very interesting thing I heard at a meeting the other day was that somebody saying that now that we have great treatments for HFpEF, it's really easy to diagnose HFpEF. And I thought that was an interesting comment too. And I'll ask Jonathan to comment on whether or not he thinks it's super easy. And maybe after this presentation, you could either agree or disagree with that comment. But my personal belief is some of these patients are easy to diagnose. Some are easy to say are not HFpEF. And then there's the vast majority that sit in the middle and you're like, I have no idea. They're short of breath and it could be 15 things. So I'm hoping that Jonathan will help elucidate some of those things because, you know, again, I always appreciate Jonathan and his insights. There was some laughing here by May, I just want to point out.
For the record.
So I'm going to introduce Jonathan, and Jonathan graduated from the University of Toronto, a pretty good medical school, not fantastic, but a good one. In 1989, the same year I did in the same class. So
You're my second favorite classmate.
not true. Jonathan sat at the front and I sat at the back, which is why he was actually involved in the development of the heart failure guidelines, and I follow the guidelines. So
Favorite classmate was my current wife.
That's true. It is.
You're number two. There you go.
That's true. It is. That is his favorite classmate, who is here and is a pediatric neonatologist. So very, very specialized, much smarter than all of us here in cardiology. Jonathan is a clinical professor of medicine at the Liberal Cardiovascular Institute, the Cummings School of Medicine, University of Calgary. He practices advanced heart failure work as well as transplant work, although I think his love is really the heart failure side of things. He's heavily involved in the clinical practice guidelines, and you'll see his name on all of the heart failure guidelines for the last probably 10 years. And he's involved greatly in knowledge translation, and it's been my pleasure to work with him on some of this knowledge translation work, both you know, with the Connect Care project, but also locally at the Rocky View. He's the former president of the Canadian Heart Failure Society, Cardiovascular Society Heart Failure Guidelines Chair, and currently co-chairs the annual Canadian Heart Failure Society update, which I will tell you is a very good update for those that are interested in heart failure, well worth going to, and I try to attend every year. Jonathan, he's going to talk to us about heart failure diagnosis and how easy it is to diagnose it. So, Jonathan.
Easy. Thanks very much. Okay, so let's see. I've learned one thing now over the years with Sandeep. Never tell him you're busy because he's always does a bajillion things at any given time. So let's see. How do I share screen? And it is this one here. And we'll go like that one there. Okay. So let's see. I don't want subtitles. It's asking me if I want subtitles, and I don't want them. Now it's in the way. All right. So I have lots of conflicts. I believe this evening. Oh, you're going to fix it. Good. Yeah. And I believe this evening's been sponsored by AstraZeneca. So thank you very much for your support. And this is not a talk about any particular products or anything like that. So we don't have to say. Yeah. So I'll just talk while you're doing that. Some of you have seen parts or large parts of this. We have a real wide range of people. You're all experts in your own field. And in recent years, we've is that the best we're going to do for size?
For everybody virtually, they can see the whole screen.
I see. So everyone should leave and get a better, everyone leave or put on your glasses and do. Yeah, this is a fairly technical talk. And hopefully you'll be able to see some of the things that are, that there may be some issues that I'll have to explain to you. So let's get started here. There's three basic parts to this. I want to give you a little bit of a history lesson from in terms of the diagnosis of heart failure. There's now a universal definition of heart failure. It's been about 60 years in the making. And it is agreed upon and endorsed by over 20 different national and international societies. And it's long overdue. It used to be whole conferences were put together and they still didn't have an agreement, kind of like a G7 summit, if you will. The second part, I want to talk about a stepwise approach. I'm going to choose one particular algorithm. There's actually many algorithms out there. They all have their advantages and disadvantages. But the one I'm going to show you and spend the most time on is actually the one that I think you would probably agree is the best thing that we can promote to general practitioners. And let's be honest, general practitioners are the backbone of our healthcare system, and they're the ones that will see most of these people for the first time. And they're the ones that can either have develop long or short delays in diagnosis. Okay. And then talk about screening for heart failure, especially for HFpEF. We'll talk briefly about that as well. I have a lot of repeated slides. I have a lot of graphic slides. And I believe Sandeep wanted this talk recorded. So this is available and the slides are available on that. So we'll start with a case. And this is something that all of us have seen at one time or another. It's a 74-year-old lady with shortness of breath. Initially thought that she was fatigued, and it got a little bit worse. Then one night after eating a salty meal, she felt a little bit worse. Really was basically sick of how she felt, so she came in to be assessed. And then a kind of a nondescript findings. NAD, does anybody know what NAD means when you look at JVP? It means not actually done. Okay, it's supposed to mean no abnormality detected, but it actually often means not actually done. In this case, I wasn't sure, but she's got maybe heart failure, maybe not, right? When you look at that. So some people would be fairly confident that it was heart failure. Other people would surveys have suggested that the confidence level would hover around 60% if you had 100 people answer this question. That's where it would be some people would be 80%. Yes, it's heart failure. Other people would be less. It hovers around 60%. So it's really hard to get a very consistent answer, especially up front before other tests are done. And so people who come in with symptoms, this lady's going to have heart failure, you know that. Because it's a heart failure talk, by the way. It's usually based on some sort of algorithm. The problem is the algorithm most people use is their gut instinct. They don't actually follow this. So here's a list of signs on the right, things that you observe, right? That's what we learned in school. And then on the left, symptoms, things that the person tells us. So most things are either a sign or a symptom. Some things like edema can be either a sign or a symptom, right? Depends on whether they tell you or whether you notice it or both. And there's a gestalt that goes in there, and there are different algorithms. Anybody recognize this algorithm? Anybody recognize this criteria? The Framingham criteria. That's what this one is, okay? And you get points in major and minor criteria, as you see on the bottom here. And in general, for acute heart failure, it's pretty good. It's about 75% accurate, okay? For outpatient chronic ambulatory heart failure, anybody want to guess what this typically will rate for accuracy? About 61%. Not much better than flipping a coin. And that's because most people who are the walking wounded, i.e. not frothing at the mouth in emerge, are much more subtle than and they don't have these findings. And so it takes a lot longer. So people tend to, the average heart failure patient takes more than 3 hours for the initial diagnosis to be made in emergencies. And that's in tertiary care emergencies, not in smaller hospitals. Part of the problem is that you don't always have the findings. And you see here, this is one of numerous collages of observational studies looking at the diagnosis of heart failure. And on the left, the second, the positive predictive value, which is the likelihood that they got the disease if they have the finding, pretty good for most heart failure findings, right? S3, orthopnea, PND. But look at the right. If it's not there, all it does is cut the likelihood down by like 50%. It doesn't eliminate it. And that's the problem with heart failure, is that it's usually not apparent, or the difficult cases, they have it, but it's not easily apparent. And so we need better tools. From this, we developed a biologic marker, BNP. It's been extensively studied. I'm not going to spend a lot of time here describing it to you because I know almost all of you, and I know that you all know what BNP is. Even the interventionalist in the crowd knows what BNP is. And now he's not a typical interventionalist. He's actually very thoughtful. So you know, we have to, he's going to get me back for that. Yes, he's looking at me now. So in all seriousness, we have BNP for acute heart failure. It actually performs quite well for acute heart failure, and we've seen that. So for the cut points in diagnosis, we have we use NT-proBNP down here in the southern part of the province. In the northern part, I believe Edmonton just switched over though. They just switched over. And so almost all of us are using it. In Ontario, it's still almost 50-50, and they're much more recently using it. And so if you use these kinds of algorithms, you have a high, a low. They have really good discriminatory value when they're really, really high, really, really low for acute heart failure. And intermediate, you're still on your own at that point. No test is perfect. And another good example there. The trouble is about 30+% of acute heart failure patients are in the middle, almost 30%. Okay. And the other trouble is this does not apply to chronic outpatient heart failure at all. Okay. Their numbers are much lower than this and therefore much harder to diagnose. So this lady, she had a BNP of 2228. Sure enough, she had heart failure. And if you look at one of these, this is actually the Boston acute heart failure scoring system. It's based on Framingham, but added BNP, rearrange a few things, and just another score to remember. I'm not going to go over detail because it's not the one I'm going to promote to you. But you can see that because of the findings that she had, an elevated BNP, dramatic rise in the likelihood of heart failure. Once you get over 85% likelihood, essentially that's what most clinicians will actually operate on an assumption at that point. Once you're more than 80 to 85% success, 80 to 85% likelihood, people just tend to treat it like that. Okay. And sure, she had heart failure. So she was admitted and her ejection fraction was 58%. She had a normal EF. She had HFpEF and improved and went home in a fairly short order, lower than average length of stay than you see in Calgary. And there are a few pearls based on this and other that this is really for people who want to go back and look at the slides. There's a couple of really interesting comments. You see here that there are certain things on echo that will point towards heart failure. You can see elevated measures of diastolic function, elevated left atrial size. We'll come back to that later. That's what LAV means, left atrial volume. Okay, it's not Las Vegas. Reduced ejection fraction, we all know what that means, and increased LV mass, surprisingly infrequent. Okay, so that's what that says in the top row. The next row, dyspnea and cardiomegaly, dyspnea and a history of heart failure. These two, it's remarkable. If someone comes into emergency and they have shortness of breath as their main complaint, and they either have an enlarged heart on their x-ray or a history of heart failure, 90% likely it's going to be heart failure. Okay, the past predicts the future, right? And the other problem is young people may get edema in funny places. They tend to get edema in their bellies. We've all seen that, right? We've all seen the young person with acute heart failure who was sent home from emergency 3 times on Ventolin, and they really had heart failure. They didn't get better. And so they could present Very, very young, very, very old people present atypically. Obese patients do not often do not have elevated BNPs, and you really, if their BMI is over 35, and especially if it's over 40, then BNP is a lot less helpful, unfortunately. And always be prepared to change your mind. So those are some negatives. The false negative BNP, especially in obesity, and remember, it takes BNP at least 12 hours to start ramping up. So if they're in acute pulmonary edema, the BNP could still be normal and they can still be frothing at the mouth, okay? Because it takes a while for it to ramp up. So what are we seeing? We're seeing an increasing likelihood of HFpEF. It's an increasing proportion of diagnosis. It's been happening for the past 15 years, partly because we now can recognize it, but also because of the demographics are changing, and it's actually occurring. Typically, the increase in HFpEF in the past was mostly related to older people, elderly, especially elderly women with atrial fibrillation and renal disease. But look what we're seeing here. We're seeing in young adults, okay? What is a young adult in the US? 15 to 44, okay? So if you add 15 to 44, that's about how old I am. And look at the last few years. We're seeing young people, okay? And most of that increase is not low EF, most of that increase. So now we're seeing hypertension, obesity, diabetes, and metabolic syndrome, inflammation. This is the toxic mix that's creating heart failure with preserved ejection fraction, HFpEF. So now it's entering into the younger people too. We're seeing young people with this condition, and we're going to have to watch it. The trouble is, how do we diagnose this early? And it's really, really tough, because these are not what the old algorithms were made from. As you can see, there have been several attempts to use diagnostic algorithms for people with ejection fractions over 50%. We used to think HFpEF was over 40%. We now know that an ejection fraction is normal at around 52, 53% and above. So 40 to 50 or 52, 53, whatever number you want to use, that's actually called mildly reduced now, okay? And HFpEF is over 50. These are not very discriminatory. And the other thing is, even though BNP is super useful for acute heart failure, with an AUC is basically the diagnostic utility of the test area under the curve. It's essentially a measure of the accuracy of the test. 1.0 means it's perfect. 0.5 means you're flipping a coin. And in acute heart failure, you can see that based on this systematic review, BNP is about 0.9 in acute heart failure, which is excellent, okay? But in ambulatory settings, it's around 0.7. So that's considered modest, okay? Low is below 0.7, and modest is 0.7 to 0.8, and good is over 8, and excellent is over 0.9, okay? And there's a real problem here. So for example, if you look at systematic chart reviews, this was published in the Journal of Cardiac Failure, you can see out of the 10 studies that were collated that there was both over and under diagnosis of ambulatory heart failure. It's highest in people who are either disadvantaged or younger people, those with less resources. And primary care has less resources. They don't have an echo lab in their office. They only have limited tools to work with. Unrecognized heart failure and COPD. 25% of people with COPD have heart failure. 25% of heart failure has COPD. Keep that in mind. They frequently coexist. All right. 1 out of every 4 of your heart failure patients is going to have COPD, and it's usually not treated. And vice versa, respirologists see a ton of heart failure, and just like we don't recognize the COPD or underappreciate it, they are the same way with the heart failure, and it's associated with these are the factors that patients had that were associated with a successful diagnosis of heart failure, and of course they're all associated with the knowledge that you're already primed for looking for heart condition. And so it makes sense that you're more likely to diagnose heart failure when you already have a heart condition, or you're being seen by a heart-centric person, or you have a heart-centric test. Makes sense, okay? So it's a big problem. Here's another issue. We know that you can't see the writing here. Unfortunately, the slide's too small. This is based on claims in US Medicare. Over 200,000 over 2 million cases. And what they did is they went backwards from the diagnosis of heart failure to see how long the symptoms that were present before the diagnosis was made. In other words, how long did you have symptomatic heart failure before someone cottoned on to what the problem was? Average, about 6 months. So these people have symptoms for quite a while before you have there's another study in the UK, which was only based in primary care, where it was, the lead time was actually closer to 2 years. Okay, so these people, especially when they presented in subtle fashion, or if they don't have dramatic findings, then they can really grumble for a long time before you recognize them. And the result is that this is the percentage of first diagnosis of heart failure made in emergency. Okay, so you can diagnose it in an office or clinic. That's where you want to make the diagnosis. That's early. You have an opportunity. The patient doesn't get admitted. They're not as sick. And as you can see here, we were looking okay in the early 2000s, but it's actually steadily gone up. It's gone up. It's gone the wrong way. And that tells us that on the one hand, we're recognizing more heart failure ultimately. And on the other hand, it means we're not getting any faster at recognizing it. We're just sort of realizing in retrospect that person had heart failure. So we need to be a little bit better at diagnosing. I'd love to do this case for you, but the writing is just too small to read. I'm going to have to skip that, but it'll be in the slides. It's nice and big on my screen.
That's what everybody online sees as well. So let's see if we just.
So this is a 62-year-old lady who's got chronic kidney disease. She's been a smoker. She's had worsening shortness of breath and was blaming it on her lungs. And she got worse in the last 2 weeks. So her family doctor saw her, started a workup for ischemic heart disease and asked for exercise tests, and noted that she had, maybe added a bit more blood pressure medication. So that's why the amlodipine is bolded. Investigation showed a GFR of 40, heart rate showing atrial fibrillation, and the MPI came back without ischemia, so no major changes were made. Okay, it must just be her lungs. And of course, what happened is she continued to worsen, ended up in hospital, and was seen in emergency. She was originally diagnosed with an acute exacerbation of COPD, it still didn't improve a lot after therapy was given, and ultimately was diagnosed after several attempts with heart failure. And when that was recognized and treated, she got dramatically better. So can we run that back? Well, the problem is when you get an echocardiogram, and by the way, when she was seen originally, she had an echocardiogram and the ejection fraction was normal, so people kind of forgot about the heart failure. It turns out that the populations with low ejection fraction very different, as you can see here. You have a gradation of age. As people present with HFpEF, they're more likely to be older, they're more likely to be female, they're more likely to have higher blood pressure. The BNPs actually fall, okay? And that's because people with HFpEF tend to have relative increase in wall thickness. The heart's not as skinny or thin, and it's not under as much stress, which is what makes the heart produce BNP. So if you have a same mass of heart, same number of grams, but one of them is dilated and thin, and the other one is smaller and thick, the smaller and thick heart is going to have a much lower BNP. And that's the analogy that you use. And they're more likely to be ischemic if the EF is lower, and they're more likely to have atrial fibrillation if it's higher. So they're quite different, and you can see that as it changes, they're different populations, and there's a lot of important changes. So one of the this is president of the Norwegian Heart Failure Society from 2018. He wrote an opinion piece that, well, it must not even exist. He was kind of like some of the people in the Mayo don't believe, or Cleveland Clinic rather, don't believe in HFpEF. Well, if it's that, well, it turns out it's just a different kind of heart failure, but it is heart failure. And you can see in graphics the same thing I was showing in the previous slide, that women are more likely to have HFpEF. They're the yellow line on the top left, okay, and men are the blue line. So lower EF, men predominate. Higher EF, women predominate. Okay, the prognosis for a HFpEF versus HFrEF, not quite as bad, okay, That's the line that you see, that Kaplan-Meier curve there, and then on the far right, you can see that the annual event rates are very, very high, not quite as high. RCT means in randomized controlled trials, and below that, observational trials. And this is just a list of studies that were reviewed. And then, because of the difficulty in making the diagnosis, we're looking for common things that you can look at that everybody with heart failure gets, and then start from there. Instead of waiting, well, they all get fluid overloaded and short of breath at rest and edema and crackles, but we don't want to wait until that all happens. We want to identify it before that happens so that we can intervene. Well, one way is you can look at gene chips. So that's a gene chip in the middle. And if you look at people who have, this is from the TopCat trial. This was a spironolactone trial in people with EF over 45. And you can actually divide people with HFpEF into 3 basic categories, okay? Hypertensives on the top, younger, good prognosis. Elderly ladies, kidney disease, atrial fibrillation, high natriuretic peptides intermediate, and then the worst, or the ones most likely to respond to the spiro, and also the ones with the worst prognosis, the ones with a lot of inflammation, obesity, and also renal dysfunction as well. So these are 3, and you can look at that. The trouble is there's a lot of right now looking at metabolomic, proteomic, genomic studies. There's just too much overlap, and we can't really reliably separate. Another way is to look at cardiopulmonary testing. Cardiopulmonary testing is a very detailed way of looking at oxygen exchange. It gives you a good idea. It's when you see the athletes on TV exercising with the snorkels on. That's a cardiopulmonary test. They're measuring oxygen consumption, oxygen dynamics, ventilation, and so on and so forth. And they're really good. Those tests are really good at separating out a heart versus a lung, or I should say cardiovascular versus a lung. The problem is they don't really distinguish that well between deconditioning, a peripheral abnormality, and a central abnormality. So people who have a peripheral muscle problem, or who are severely deconditioned, or who are sick from, say, cancer, they're going to look an awful lot like someone who actually has heart failure on the cardiopulmonary test. And the other problem with the cardiopulmonary test is if you can't exercise for at least 3 or 4 minutes, it doesn't give you as reliable information. And finally, people who are highly symptomatic, they can't go very far on the test, and so you don't get enough data to tell the difference. Now, it's an excellent test, and we use it to tell if people should get heart transplants or not. And it is discriminatory, and it is part of your pathway if you want it to be. It's just not perfect. One thing that we've known has happened in acute heart failure is that the pressures in the lungs go up, and they go up several weeks. That's weeks, not days, but weeks before they actually present to emergency department. So maybe there's something about the PA pressures or the filling pressures that we can get at. And this was first shown in invasive studies of people. This is from one of those invasive devices where you put it in the pulmonary artery and then it measures pressure. And as you can see it climbing and climbing and climbing. And then finally they get admitted and it dropped because they got admitted to hospital and got diuresed. That's why it drops. And so this was very consistent, and people began to change the paradigm of acute heart failure. We used to think that the symptoms happened at the same time as the congestion, but now we walk it backwards and realize that the congestion actually starts with an increase in pressure. It's not always an increase in weight. A lot of times it's mobilization of fluid from other compartments in the body. And the biggest fluid compartment in the body that you've never heard of, or some of you've never heard of, is the splanchnic circulation. Okay, it's like the bullpen of the circulatory system. You know, the bullpen at the airport where all the taxi cabs wait and wait and wait and wait, and then they come one by one to pick up people. Well, that's the bullpen. They call it the bullpen. And that's where all your extra venous blood sits. About 70% of your venous blood volume is in the bullpen. And all it takes is a little bit of constriction or a little bit of mobilization of that blood in the bullpen, and you're short of breath. Okay. And so that's why the pressures go up without a weight change. That's why 50% of people with who are admitted to hospital with heart failure don't have a weight change. We only pick up about half or less of them with our weight changes. That's why. And so there's this period of time where you have abnormalities occurring, and then symptoms actually one of the last things to happen. One of the last. That's why we want to wait we don't want to wait until they present to emergency. We want to find them as early as we can. So this directed many researchers, and so the folks at the Mayo really got onto this, and they started looking at what makes someone have HFpEF versus just a hypertensive. So they began to look at echocardiographic estimates of the PA pressure, the RBSP on echo. And sure enough, they found that people who had, just like in this graphic here, people who had HFpEF were diagnosed with it, had higher PA pressures. And they said, okay, we'll find enough. Let's see what happens, whether or not they have a full-on diagnosis of pulmonary hypertension. And sure enough, those who had HFpEF were more likely to have that as well, based on versus people just with hypertension. And then they took it one step further, and Barry Borlaug, who actually gave a talk here in Calgary a few years ago, he was one of the pioneers and leaders in this. A couple of other guys too, Sanjeev Shah and Ryan Tedford and so on and so forth. They really led this out, and they began measuring pressures with actually a right heart catheterization in small groups. This is actually, I think there was only about 14 or 16 patients in this study. And look how tight the data is. People who didn't have heart flare are in the black, and people who did, they had hypertension, but they didn't have heart flare. And then people in the red had heart flare. And you can see at whether they got a saline load, you can see that there's a change in the wedge that's 3 or 4 times. So the wedge pressure is the equivalent of the left atrial filling pressure. And you measure it with a catheter in the pulmonary artery, for those of you who don't work in the cath lab. And you can see that just giving a little bit of saline here, it's 500 cc, okay? And then if you get them to exercise, you even get a more dramatic. And this is very, very light exercise. And we've since this actually just raising their legs, you can get that kind of a change too. It's actually an intermediate difference between, you see the difference in the saline on the left and the difference in the exercise on the right. There's, well, think in your head about half of that difference. That's what just a simple leg raise is. No exercise, just raising the legs. The pressures go up. So we have a very non-compliant cardiovascular system. So this is really too small to see, but what it is it shows prognosis of an unselected group of patients who, about 500 patients in this study, and it's the prognosis on the y-axis, and then on the x-axis is time. Okay, so it's a survival curve, and then in the different colors you have black at the bottom. There are people who have pulmonary hypertension at rest, and then pulmonary hypertension with exercise is the red one, and no pulmonary hypertension in the blue. And you can see that they have on the left. Now, in the other three, the 3 right-sided curves, we've actually measured the pulmonary hypertension or elevated pressures in a different way. We actually divided the change in the filling pressure, the wedge pressure, by the change in cardiac output, because when everybody exercises, their cardiac output goes up, right? That's what's supposed to happen. Well, if your wedge goes way up and your cardiac output only goes up a little bit, that indicates a very non-compliant system that's consistent with heart failure. That's what we expect to happen. And so the red line are those whose ratios went up by more than it should have. And the blue line are those where it did not, and they have a much better. So because of that, we now have a fairly standardized exercise test that is thought to be easily the most sensitive indicator of an abnormal cardiovascular system. And this is now going to be our gold standard for diagnosing heart failure. So we work back from this, okay? And so this is a graphic of the test that we have. On the top, you see what the pressure tracings look like: the right atrial pressure, the right ventricular pressure, the PA pressure, and then on the right, the wedge pressure or the pulmonary artery occlusive pressure. You can see that that's what they look like when they're nicely traced. And you can see in the third row, there's someone lying on a table on a supine, that's called supine exercise. And it's an ergometer, basically a fancy bike, and it gives resistance. Turns out you get your answer super quick. Within 2 or 3 minutes, you know what's happening with these pressures. They either shoot up or they don't. You don't have, it's not like with regular exercise tests, you have to get the heart rate up to 85% of predicted, right? In order for it to be an adequate test for ischemia. Not with this. With this, you're looking at 20 to 30% of maximum exercise. And then you can see the stepped exercise exercise intensity, that stepped increase in resistance. And then on the far right, you see the ratio or the curve of increased pressure divided by the change in cardiac output. And you see the steeper the curve, the blue one is the pulmonary artery pressure curve, and the green one is the wedge pressure curve. You can see the steeper that it is, the more likely it is going to be heart failure, the more likely it's abnormal. So the gold standard now for heart failure diagnosis, if anybody whose pulmonary artery wedge pressure is over 25 at peak exercise, then that's always abnormal. In young people, anything under the age of 50, anything over 20 is abnormal. Okay, anything over 15 at rest is considered abnormal. So hemodynamic criteria for heart failure. Okay, I'm going to skip that slide. So if you compare different tests, you can do an exercise echo. You can estimate PA pressure with echo with an RVSP. You can estimate filling pressures by echocardiogram. You can do exercise echoes. You can do the diastolic stress test invasively. And what you find is that you can separate them out using these different tests. Doing an exercise echo is very useful as long as you get a good study. Okay, as long as you get a good study. It turns out that you can miss increased pressure with the Doppler because it's an estimate. It's not the actual measurement, so it's not perfect. But on the right, you see when they have non-cardiac dyspnea, usually due to lung disease or something else, if you're actually measuring the pressures, they never go up. And that's a perfectly negative predictive value that you have. So, for example, here's somebody who has exercise limitation, okay? And he had a bone marrow transplant, he was short of breath. So people, I don't know if you know this, but people with bone marrow transplants, they get short of breath and they get fatigue. But his lasted longer than a couple of years. And so he was getting worried and maybe there's a cardiac limitation. So he had left ventricular hypertrophy on his echocardiogram, but it was an old finding, he had an old history of hypertension. So we're going to sort it out. And you can see that middle line here, okay, that's 25, okay? That's 0, that's 25. So this looks to be a little under 15, okay? Normal. That's a wedge tracing, by the way. And when he's exercising, and we really pushed this guy, 150 watts is about what a middle-aged person should be able to do, working really hard, okay? And I'm not going to define middle age for you. And you can see that the wedge pressure, it's this is a scanned copy, so you can't really see it, but it looks better. It looks much better on this screen here. The actual end expiration pressure averaged at 16, so that's well below 20, not to mention 25, and he had to stop. So he did not have a cardiac limitation to exercise. He had another limitation to exercise. Here's an example of a positive study. This is somebody who had an ejection fraction that improved from 20 to 50%, but they were still short of breath about a year later. What's going on? And everyone said, no, your heart's okay, you're crazy. So we did her exercise test. And on the right, you can see that the mean pressure, you see that circle, that's a 29. So this range was much higher, it was 100 range. On the left-handed panel, this is during exercise, we see the PA pressures went so high that they went off the scale. We couldn't see the top, 75 systolic. And the wedge pressure, which was normal at rest, went up to 25. So there's clearly was a cardiac limitation in her case. This is a younger person here who's resting hemodynamics. You can see that we were doing two measurements at the same time, two different transducers. And that's the PA pressure and that's the RA pressure here. He had shortness of breath and mild mitral regurgitation on echo, but he couldn't do nearly what he used to, and he didn't know why. Everyone was saying, no, he thought it was his mitral valve. And everyone said, no, you got mild mitral regurgitation. So what's going on? So we did an exercise test with him, and his PA pressure shot up to 60, and his wedge pressure shot up. You can see so this is his PA pressure here, okay? All right, that's all right. PA, okay, just look at that, same range. Now look, oops. Now look, the Dean, you'll recognize this right away. These are nasty, nasty B waves, and they're almost the same as his PA pressure because his mitral valve just opened up while he was exercising. He had severe exercise. Now you say to me, well, why didn't you do an exercise echo and show this on the echo? And well, we did, but unfortunately with all the respiratory artifact, we never really got good enough pictures. So we had to do it this way. And he ended up doing much better after and then finally we have this person here where we were doing all of these ratios. He's a guy who was very short of breath, had a ejection fraction in the mid 40s, and we didn't know why. He had a family history of cardiomyopathy, so we exercised him because he was complaining of shortness of breath but was afraid to exercise. You can see that his resting pulmonary artery pressure was completely normal. His resting wedge pressure on the right was completely normal, with exercise, it really didn't go up very much at all. And he was just out of shape. And so he actually went in an exercise program and had significant improvement in his symptoms. So that's sort of where we're working with diagnosis and getting backwards. And you're going to say, well, does that mean we have to send everybody for these tests? No. This just represents a standard by which we can work backwards and get better algorithms and better simplified manner of identifying these people. And then we have a go-to test in situations where we really need to know, or the cases are really complicated or unclear. That's the bottom line. So we have cardiopulmonary exercise tests, really good for prognostication, well established, good at separating out lung and heart disease. They can provide great detail for a variety of conditions that you would never otherwise diagnose. The exercise echo, I think, is something that's vastly underused here. We do almost all of our exercise echoes are either for aortic stenosis or ischemia, right, Sandeep? Because you read them.
Yeah.
99% of them are those two, right?
Yeah.
Well, I personally think that this should be a go-to test for if you're not sure if your patient has heart failure. I don't think they should all go right to invasive testing. I think you should reserve that for when you still need it. But if you have to, the exercise right heart cath will tell you, do they have a cardiac limitation or not? Because if their pressures shoot up, they do. And if their pressures don't shoot up, they don't. Now, it may not tell you why they have a cardiac limitation. Maybe they went into rapid atrial fib. Maybe they have ischemic heart disease. Maybe they have valvular heart disease. You're not going to know based on the pressure because it's just a pressure. But you are going to know if it's a cardiovascular reason or not. That's for sure what you're going to find out. So working on this backwards on several large cohorts of several hundred patients, and there's several centers that have looked at, can we get a score? Can we get something simpler than Framingham that will tell us whether or not someone is likely to have HFpEF or not? We didn't really apply this to HFrEF because once you have the low EF, it's a lot easier to make those diagnoses. So you can't see this, but this is a regression. This is the results of a multiple regression of several factors after they had gone and adjudicated all the cases as to whether it had heart failure or not. And they came up with something called the HFpEF score. And it's quite simple. And you can see the H2 means heavy and hypertensive. The F means atrial fibrillation. The P means pulmonary hypertension based on an echo, a resting echo, our right ventricular systolic pressure above the threshold that you can see there. E means elderly. I think you all know what that means. Okay. And F means filling pressures, again, estimated by echo. And there's a measurement called an EE prime that is the ratio of tissue movement during diastole and divided into the velocity of blood. And the thinking is that the heart's really stiff if the velocity is high, but the tissue doesn't move, right? Kind of like strumming a really tight guitar string, if you will. And so the higher that ratio is, the more likely that the pressure is high and that the heart is stiff. Okay, and 14 is usually the number that is bandied about, but anything over 9 or 10 is actually not really normal. So that's why they use that number 9, because it's abnormal. 14 is really predictive of a high resting pressure, but 9 is not normal. It says it's stiff. So you look at the number of points, And then you add them up. And if you could see on the bottom, there's total points. And then underneath it, which is in scale, the likely percentage that is going to be heart failure. So this is something that I think a lot of family doctors, a lot of primary care, NPs, family doctors, primary care, they're going to probably get this. They're probably going to get this. And if you're greater than 5 points, it's highly likely. If it's 2 points or less, it's not. And if it's 3 or 4, which unfortunately, significant portion of patients end up in that, you're still not sure, just like every other score that we use. So let's go through a stepwise approach to the diagnosis. The definition, the universal definition of heart failure has been, now that it's agreed upon, I'm going to go through a few basic parameters. It turns out that it doesn't start with end-stage heart failure, or it doesn't start and emerge. That's kind of where we thought it started years ago. It's not where it starts now. Where it actually starts is just like atherosclerosis. It starts in people who have risk factors. And you can go straight from stage A through to stage B into stage C without even realizing it. So stage A are people who are at risk for heart failure. And it's a large bucket. It's people with cardiovascular risk factors. It's people with family history. It's people who are getting chemotherapeutic agents. It's people who are self-toxifying, shall we say? Okay. You know, they spend too many nights at Santini eating dinner and drinking wine, stuff like that. These are the risks. So the risk factors are all written down. So this, you can't read it, I don't think. It says hypertension, cardiovascular disease, diabetes, obesity, exposure to cardiotoxic agents, genetic variant for cardiomyopathy, and a history of cardiomyopathy. Okay, that's what that says. I just wanted to read it to you because I'm pretty sure you can't read it the way it's shown there. Stage B are people who have a structural heart abnormality, but they don't have symptoms. Okay. Yeah, and so they're stage B. Okay. This is based on the AHA definition. Stage C, that's the heart failure we know and love. They got the abnormalities, they got the symptoms. And then stage D are the hardcore end stage cases. These are people who you either palliate or you send them for advanced heart failure therapies, or sometimes both, right? Seriously, I'm not lying. But that's the big change in looking at it. It's a continuum. It's not just only heart failure and nothing else. Things lead to it, and it's important. So symptoms are not yet present. Symptoms are now present. That's the difference between B and C. And you're going to see more and more. So how do we actually make the diagnosis? So in heart failure, you need 3 things. You need symptoms, because without symptoms, you're in stage B or A. You need the symptoms. Secondly, you need something wrong with the heart. Okay? You need something structurally or functionally wrong with the heart. You'll be surprised at what it is most often. And then C, which is really what has tripped us up most of the time, you need objective evidence of congestion. Okay? Objective, and there's multiple ways to get that. So what do we see most often? Well, the symptoms we'll talk about that all day. You know what the symptoms are. It's 90% of them are short of breath, 80% of them have fatigue, and about 50–60% of them have either orthopnea, PND, or progressive exercise intolerance. The most common structural abnormalities for people with HFpEF. Anybody want to guess what it is? With HFpEF, most commonly seen structural heart abnormality. Nobody wants to say? Okay, I'll show you. Sorry? Left atrial enlargement, ding, ding, ding. Now, what else do you need? Objective evidence. There's multiple ways you can get this. You can get it from the old standby natriuretic peptides, but in ambulatory settings, it's a lot harder to do that because they're lower. So they're not going to be as predictive. You have to get other things usually in the ambulatory setting. So you're looking at chest X-ray findings. You're looking at direct pressure. I'm going to do that again because it's not supposed to. There. And yeah, it just disappeared. So I don't know why it does that, but it does that sometimes. So you can look at chest X-ray. You can look at direct pressure, and you can look at BNP. And then there's one other way that you can look at this that's more recently advocated. Anybody want to guess what that is? Jordan, you know. Yeah, called POCUS. Anybody ever heard of POCUS? I don't mean hocus pocus. I mean POCUS, point of care ultrasound. So you're going to see that more and more. In fact, the emergency folks, they're going to training sessions on this left, right, and center. The internal medicine group in Calgary has a longstanding POCUS program. So it's something we need to know about because this is our bailiwick and we don't want to get left behind. And you know what? If it's done properly, there is value. There is value. So I already talked about mitral inflow velocity. That's the velocity of blood going across the valve. I'm not going to get into much detail. You can look at the velocity of, this is the velocity of the annulus, so it's tissue velocity. Okay. So those are that's when we talk EE ratio, that's where it comes from. And sometimes the pictures aren't much better than that, Sandeep? Here's the slide I wanted to show you. It's way too small, unfortunately. These are the findings of cardiac structure in large randomized HFpEF trials. And what it says, the narrow one says, how often was it that LV hypertrophy, LVH, got them in the trial? 10%, 10 to 20% of the time. If the bigger box is what percent of them got into the study? Because in order to get into the study, you had to have an abnormal heart. So this is the abnormal heart part of it. And the abnormal heart, about 10% of it was an abnormal EE ratio. About 10 to 20% of it was LVH. 90% of them had left atrial enlargement. So almost 9 out of 10 people who we got into these trials, we got in because their left atrium was enlarged. So it's not close. That's by far the most likely thing you're going to see in somebody with HFpEF to help you make the diagnosis. So if you get a report, then you're going to look at ejection fraction, which is circled. You're going to look at that left atrium. And you're going to look at the RVSP, and you're going to look at the EE prime. These are all things, ejection fraction, left atrial volume or left atrial size, EE prime, and the RVSP. These are standard reporting of every, the ASE, the American Society of Echocardiography, says that you have to have those 4 things to have an adequate report. Okay. So that's why I have big LVEF, of course, for the low EFs, and then LA enlargement. And then all the others are nice to have and less common. What about POCUS? Well, here's what we see here. See on the top, this is a lung POCUS. So a lung field, you see the ribs going across, and then you have those curvy horizontal lines. They're called A lines, and they're normal. On the right panel, it is a very dense single line. That's what a consolidated lung looks like. Okay, like pneumonia. Also, severe interstitial lung disease can look like that. On the left, you can see those little lines that are going down, multiple lines on the right-sided panels. Those are called, Jordan, what are they called? Yeah, called B lines, not A line, they're called B lines. And if you have a certain number of B lines, then that's indicative of edema in the lungs, i.e. congestion. And so it's very useful. So look at this person, I don't know, they're nasty. Look at all the B lines there. If you have 3 to 5, that's a lot. This person's got like 10. All right. So that's like me after my monthly visa bill right there. Okay. And then you can look at other things too. You can look for pleural effusions, right? That comes with heart failure. And you can look at the inferior vena cava. You can do that on a regular echo too, but you can also do it. And if you have a dilated inferior vena cava, that indicates likely the high pressure, high filling pressure. So these are the things that you can look for in POCUS, and that also counts as objective evidence. And honestly, POCUS, when it's done properly, is at least as good as a BNP. It's not as well studied. And with a BNP, you have a standardized test that's done in a lab that you don't have to worry about the quality. But POCUS is much more quickly available if you have the machine. All right, I'm going to skip that. The other thing that about heart failure diagnosis is It's now divided into 3 types of ejection fraction plus another. So the 3 types are heart failure with reduced EF under 40. You guys all know this. I won't spend a lot of time on it. Mildly reduced. It's not mid-range. It used to be called mid-range. It's not mid-range. It's low. So it's mildly reduced. And then heart failure with preserved EF. And for simplicity, we've decided to choose 50. Okay. It's not quite normal. You could fudge on the numbers, but we're just going to use 50 because it's an easy number to remember. And then there's another entity which finally there's been agreement on it. If the ejection fraction improves by more than 10%, it's heart failure with improved ejection fraction, and their survival curves fairly closely mimic those with HFpEF. Okay, much better than HFrEF. Okay, so improved ejection fraction. That's there's the 4th category that I told you about. Okay, and then finally there's a trajectory. Okay, and the trajectory indicates new onset on the left. The resolved or stable, so-called stable, we call it resolved now because these people are never truly stable. If they're truly stable, it means we've cured them. Very few people with heart failure are ever cured. Persistent heart failure, this is when they still have symptoms, okay? Stole a term from the HFpEF folks. And then worsening heart failure, this is an increasingly used term. And these are all agreed upon, so you're going to see these terms in the future. So heart failure, diagnosis, stage A, B, C, or D, or at risk of heart failure, pre-heart failure, symptomatic heart failure, and advanced heart failure or stage D heart failure. You have the different ejection fraction categories, and then you have the trajectory. Are they getting better, worse, or the same? So if we get back to our score, I just wanted to show it to you again. You get 2 points for elevated BMI, 1 point for antihypertensive agent. You get 2 points for atrial fibrillation. You get 3 points for elevated RVSP, okay, on echo. You get 1 point for being over the age of 60, gulp. And you have 1 point for having an abnormal EE prime. You guys are all going to get there too, okay? So don't laugh too hard. All right, so Our Lady that I showed you, that the print was too small for you to remember everything. She had 6 points, so she's at fairly. If you look at 6, she's about 0.85, 85% likely to have heart failure. All right, so sure enough, she had a left atrial abnormality. She had an RVSP that was high. She was diagnosed and she was treated early and managed to avoid an emergency room visit. That's the whole idea here, seeing them a little bit earlier. So we could have avoided this. We could have avoided her presentation to emergency by recognizing it and using the tools and the algorithms to help us. I'm going to skip that. So the algorithm is to listen to the patient, talk to them. You can use a score or not, as the case may be. And if you think it's heart failure, then treat them that way, if you're pretty confident. If you're confident it's not heart failure, then treat them for whatever condition that they have. If you're still not sure, then I would advocate that you do non-invasive tests first. Make sure you get your BNP, and then if it's available. Now, we don't have a lot of capacity for exercise echo, so that might be an issue, and Sandy may have something to say about that. But to me, that's the natural step. But there's often reasons why you can't do it. The windows aren't good, person doesn't exercise very well, it hasn't been validated for dobutamine yet, so you have to be able to exercise to do it. Cardiopulmonary exercise test, you really have to be sure that they're going to be able to exercise more than 3 to 5 minutes to get the good steady state numbers there. And if you're still not sure after that, then you may need to do an exercise, a hemodynamic test. So that's sort of where we're going. Now, that's HFpEF. That's the one that's simple enough for primary care. Okay, we're getting towards the end here, so don't worry, folks. What about those of you who like a much more detailed approach and you like hard numbers and a little more detailed score? Then you use the European one, which is called the HFpEF. Okay, it was published a couple of years ago, and it goes in different stages. So again, this is way too small. I'm not going to spend a lot of time on it. You can go back and look at the slides, or I can send you the citation if you want. But essentially, there's 4 different steps. The first is the clinical assessment to decide if they're at high risk or not. And if they're not at high risk, then you treat them for whatever condition you think they have. And if they still have findings that are suggestive or compatible with HFpEF, then you actually do the score. So these are the risk factors that tell you whether or not they're at risk for HFpEF. The next step is to do the score, and there's 4 categories: biomarkers, which is blood work, and 3 categories: biomarker thresholds for when there's sinus rhythm. That's what the SR means. Biomarkers, if they're in atrial fibrillation, they're different because atrial fibrillation will make your numbers go up. And then you have left heart morphological findings. It's more detailed than the HFpEF score that I told you about before. And then the functional gives you more detailed numbers there. So some people like this because there's a much greater discrimination amongst scores. What else this does as well is it gives you an idea of when to do either your exercise echo or even an invasive test. You can see on the top, there's an echo stress test that gives you parameters that will help you decide whether it's positive or negative. And on the bottom, it shows you what the parameters are for a positive exercise hemodynamic test. If the wedge pressure is greater than 15 at rest, that's abnormal. If it goes over 25 on exercise, that's abnormal too. So those are the thresholds that you use. And then finally, it gives you a suggested workup, because remember, one of the things that can mimic, especially if they're not volume overloaded, one of the things that often mimics heart failure is ischemic heart disease. And you always need to make sure that's not one of the reasons why they have that shortness of breath, because the exercise hemodynamic test will look the same, whether it's ischemia limiting the heart, a valve disease, or a rotten ejection fraction, right? It'll look the same. The difference is it'll be ischemia. So you always want to look for ischemia, and we can't forget that. I'm going to skip that slide too. This is just to indicate that this particular validation suggested that the European score this validation, we looked at our own Alberta Heart Group, and we found that the HFpEF wasn't as discriminating. The area under the curve was only about 0.7, so that's not excellent. So what does that mean? It's still early days. It's not gospel, and you have to keep thinking. You always have to be willing to change your mind, just like I said with those pearls. This slide is to indicate that other studies. This is an American study. So the HFpEF score that I showed you originally, that's an American one. The European one is that complicated algorithm. This was done on American. So most of the American studies show superiority of the HFpEF score. Most of the European studies show superiority of the European score. So pick your poison. That's why I'm promoting the simpler one, because it's simpler. It may be better, it may not be better, but at least it's simpler. And you can see here the AUC was considerably better with the American score than it was. Okay, now you say to me, last part. Should we screen for heart failure? Because right now there's no recommendations in Canada to screen for heart failure. Well, if you take a group of Canadian adults over the age of 45 and you add up, okay, these are Canadian adults over the age of 45. If you add up all the people who had something wrong with their heart, i.e. diastolic dysfunction or low EF, whether or not they had symptoms. So anything wrong, they could have no symptoms but an abnormal EE prime, no symptoms but LVH or left atrial abnormality or a low EF, plus everyone who had symptoms with all of those. Anybody want to guess what percentage of the population that'll add up to? So I hear high numbers over here. How about 4 to 7%? 4 to 7%. So we screen, anybody know what the threshold for screening for colon cancer is? The estimated prevalence? 2%. And yet we don't screen for heart failure. Okay. Why is that important? Well, this slide here is from an old trial, a hypertension trial. And the very first thing to happen to these patients, you can see on the upper right, that's the incidence of myocardial infarction being the first event, heart failure being the first event, stroke being the first event, or all-cause death being the first event. They're all approximately equal, except for the all-cause death that went up. In other words, if you have high-risk hypertension, you're just as likely to have heart failure before any other vascular event. It's an equal opportunity condition. So it could be the first thing that you get. There are screening studies in high-risk populations. Here, this is a group of diabetics who were screened with BNP. And if it was over 125, they were put into an intensive program. They had an ejection fraction measured. They were put on RAS agents, beta blockers. And as you can see here, over time, they had fewer cardiovascular events. Another trial called Pontiac showed the same thing. Okay, and you add both of those trials together, you have approximately 800 patients. So it's not huge, but they showed the same thing. So for the first time this year, the American College of Cardiology now says, see that 2A recommendation, in patients at risk of developing heart failure, you can do a BNP or NT-BNP as a screening test to look for the development of heart failure or the risk of heart failure. So there is now, for the first time, from the American College of Cardiology, a recommendation, not a grade 1 recommendation, but a grade 2A recommendation, which is a strong suggestion that you can screen people. And the most common reason for screening them, people with diabetes over the age of 55 or diabetes greater than 10 years. Okay. And by the way, for those other 2 trials that I showed you, they're all diabetic patients. So the ADA, the American Diabetes Association, has endorsed that recommendation. Okay. So remember, symptoms not yet present, symptoms now present. Consider screening people who are at risk, high risk populations. And you can also target patients who are screening who have structural heart condition, but not yet symptoms. You can screen that. I'm going to skip that because we talked about it as well. So long talk, lots of numbers and lots of slides. I apologize for that. I did that on purpose so that stuff would be available for people. I hope I didn't confuse you with the whirlwind tour, but I think we're starting to coalesce into a place where we can diagnose heart failure a lot easier, act sooner, and hopefully prevent events. So thanks for your time.
Jonathan, thank you for that enlightening talk. I think having the background of the hemodynamics for those that were interested was very good, but you still kind of brought it back to the primary care. So thank you.
Yeah,
For a simpler people. There were a number of questions, a few of them in the chat. So I'll go through them and then I'll ask the audience here. And again, thank you for reminding me to thank AstraZeneca for the presentation today. So one of the questions was in regards to going back to the Boston heart failure score. One person asked, well, why was the absence of fever given 2 points? Is there a reason for that, or do you?
Yeah.
I mean, that's a few slides ago. So
good question. I hope the person can still hear me. That's a really insightful question. I thought the same thing when I saw it for the first time. So what happens is the way you develop these scores, if you take all comers with a chief complaint of dyspnea that come into an emergency department, and then you look at all their characteristics and you adjudicate all the cases, usually after hospital discharge, and you put them into their diagnostic buckets. And it turns out that people with heart failure rarely get fevers, but people with pneumonia frequently get fevers. So the absence of fever is really an indicator that it's not pneumonia. Okay, that's the reason.
Yep, and
good question.
That was what they sort of suspected. The next question was in regards to phenotyping. So the question that they had, and I have a subsequent question, was in phenotype 3, which is the obesity type, for those that don't remember.
Younger male obesity and inflammation, yeah.
Right. So why did they respond to Spiro, or why do they respond to Spiro?
I don't know.
Their point was, is it because obese patients have high renin? Is that a possibility?
Could be, because they did have high renin.
Yeah.
It could be. And Spiro blocks downstream effects of renin. It doesn't block all the effects of renin. I don't know. That's as good as explanation as any that I've come up with. There have been multiple other. It just may be that this is a group that they have a large inflammatory burden, and because of that, they're more prone to developing fibrosis. And we know that in dog models, for example, there is no substance that inhibits cardiac fibrosis in dogs more than spironolactone. So it may simply be that it's an antifibrotic agent, and it's actually blocking the aldosterone, not necessarily the renin. But I don't really know.
So in a subsequent question to that, because there's a number of different groups that are proposing different phenotypes for HFpEF, right? Some have 3, some have 5, some have 7. It's like there's all these different groups. So do you believe at the end of the day, phenotyping will help us figure out which drugs to use or which treatments to use in these patients? So for example, there's a study to using GLP-1 receptor agonists in obese diabetics, to see whether or not they can improve, that particular population. So do you believe that phenotyping is going to help us?
Yeah.
Or is that just, a red herring?
I think it would if there was enough of a will to look at it. The concern, that's one of the reasons that this hasn't happened before is that the funders of clinical trials have decided not to spend money figuring out which of their patients don't need their drug. For example, there's the ACE allele. And there's a large group of people who think that people who have the DD ACE allele, and you know what I'm talking about, they don't respond well to ACE inhibitors. Their blood pressure is not as well controlled, and that maybe they don't work in heart failure. Another group, African Americans. A lot of people don't know that in the original SOLVE trial, African Americans did not see a benefit with enalapril. And maybe, and then there's also a beta receptor gene polymorphism that predicted non-response to beta blockers. But the thing is, they were never followed up by a properly designed trial to prove that the hypothesis worked, because there's concern that, and let's face it, if you're a funder, or if you're making a product, say a drug, and you're spending upwards of $1 to $2 billion to bring it to market, you don't want to spend an extra $300 million to identify a group of people who might not benefit from your drug. So that's a real issue. It's a real issue. And the result is that there's, unlike the oncology group, where they've really chased into the, but they've also been able to expand their indications. Here, they've taken the overall bucket approach, and then to further define people who don't need their drug, it actually reduces the market size. So I think that's the irony of that whole situation. I do think if there was enough will to do it, that we would be able to show groups that should and should not be treated. I think the obese patient is a really good example of that.
Right.
Yeah.
Yeah, because they seem to be a very special population.
Yeah.
And you talked about the different stages of heart failure, and particularly in the prevention of heart failure component of it. And I just want to ask you your opinion. I mean, it seems like we've already got that there with SGLT2 inhibitors and the prevention of heart failure. It seems like inadvertently, we figured that out to some degree. So what do you want to just comment about the stage A and prevention of heart failure?
Yeah, so I don't want to steal thunder for whoever talks about the treatment of it, but you're right. Prevention of heart failure.
It's okay.
Prevention of heart failure is huge. That's actually the HFpEF trials. I've spoken to the people making the recommendations. They admit that that's the reason that recommendation went through, because of the SGLT data. But don't forget, there's data now with ACE inhibitors. There always was, that you could prevent heart failure in people with diabetes. And there's some evidence that people with diabetes and high heart rates and cardiovascular disease also have a protective effect when you treat them with beta blockers, and that that you can prevent the onset of atrial fibrillation in those groups of patients too. So yes, prevention is these people are difficult to treat, and preventing, especially HFpEF, super duper important if you want to make a difference.
Now, we have a number of clinical trials that have not shown benefit in HFpEF. The question I have, because we talked about diagnosis and we saw how easy it was to make the diagnosis based on what Donovan showed us. So the question really is, did they actually have the right patients in that population? And is that the reason why the trials were negative? We know for sure there was probably that happening in TopCat.
Yeah.
Was that also true in the other clinical trials? And we're talking about diagnosis here, not treatment, but it's relevant to the treatment aspects of things. So what are your thoughts? Did they have it all wrong? Did they get the wrong patients? Or did they have the right patients and the drugs just didn't work?
Yeah, I think it's basically we didn't have the guts to do the right trial. So if you say TopCat, that was a clear mistake that no one saw coming. It turns out that a large number of people in Top Cat likely did not have heart failure. There's lots of reasons why, and probably don't want to talk about them now. But if you have a properly selected group of people with high BNPs, a rock solid diagnosis of HFpEF, it's likely that spironolactone is useful. That's why it has a weak recommendation in favor of it. We have, going back to the original trials, like the CHARM, there's an old trial called CHARM that many of you don't remember, probably just you and me and Dean probably. And in that trial, it was a trial of an ARB to prevent events in HFpEF. It was called CHARM Preserved. And that trial showed just a small signal for hospitalization. But the trouble is 2/3 of those people were already taking an ACE inhibitor. So they didn't really have the guts to treat it against placebo. And similarly, the more recent trial, Paragon, looking at an ARNI versus an ARB, and they did it because they didn't think they'd be able to recruit patients to ARNI versus nothing. So they didn't do the right trial. And the result was a mealy-mouth, almost positive trial. And if you do imputation and taking the CHARM trial and then adding to it the Paragon trial, you would have gotten a very similar result from the original SOLVE trial with an ARNI and HFpEF. So I do think there are drugs that work. Again, for a different day, but if you look at, there's several therapies that have really steep curves. So if you imagine on that we're looking at a slide here, and on the x-axis is the benefit or the benefit of a drug. So you have the line going across the middle, and then you have this regression curve where you go ejection fraction on the bottom, and then you have the benefit of the drug, and it's usually the hazard ratio is 0.5, 0.7, 0.8, 0.9, and it's all below that 1.0. And all through ejection fractions, if everything works, no matter what the ejection fraction is, that line's going to be straight across, right? Well, it turns out that for SGLTs, it is almost straight across. Okay, turns out it is, but other drugs are not. They're really steep is the beta blocker. Beta blockers are beautiful up until you hit 40 to 45, and then they shoot up straight. Beta blockers have no benefit for HFpEF, none. The only thing they're useful for is controlling atrial fib heart rate, really, or maybe ischemia. But honestly, if they have ischemia and their EF is 55%, then they should be sent to Dean for an angioplasty anyway. And then the other drugs like the ARNIs and the ACEs and the ARBs and the MRAs, they're not flat like the SGLTs. They don't have that hockey stick that beta blockers have, but they are slightly positive, and the benefits attenuate. That's what it looks like to me.
Yeah, and I think one thing that you said that was really relevant was all these other trials, they did it against other drugs and they weren't able to show as much benefit.
Yeah.
But SGLT2 did it against all those drugs. They had very good enough percentages of those patients.
But they were placebo-controlled trials.
I understand that,
Yeah.
but this, and they all showed benefit. So I think that in HFpEF population, I think that's an impressive.
Well, easily the best data set for HFpEF lies with the SGLTs, no question.
Yeah.
Nice, clean trials, well done. And it gave us our answers, thank you. Right?
Now, questions from the audience in the room. Oh, is there another one online? Does treatment of obesity reduce the risk of heart failure, especially HFpEF?
Yes, long-term follow-up of obesity surgery. The biggest signal is a reduction in heart failure.
And that's, I guess, partially the reason why, GLP-1 receptors are looking at that.
Yeah.
And question around mechanism. Is it just decrease in body mass?
No.
Or is it decrease in pericardial fat? What is, or is it something else?
Yeah,
What is it?
No, you're right. So it turns out, it's a good question, and very insightful. So you already know this. It turns out that there have been studies done looking at CT scan measured pericardial fat. You can actually estimate the amount of pericardial fat by CT scan, rapid CT scanning. And it turns out that the risk of subsequent heart failure is dramatically risen. Way tighter correlation than MI, way tighter correlation than stroke. It's the correlation with subsequent heart failure if you have increased pericardial. It's also atrial fib too, by the way. So it's associated with atrial fib. It's associated with and then changes in pericardial fat also correlate with the risk of heart failure. And it actually correlates better than BMI. So these large follow-up studies have said, does BMI predict heart failure? Yes, it does. Does pericardial fat predict heart failure? Yes, it does. Which is better? Easily, pericardial fat. Yeah.
So on a corollary question, because we don't, as an echo doc, and I'll fully admit it, if we see a bunch of pericardial fat, we're not reporting it
Nope.
in our report. So does it matter? Should we be reporting it? And in particular, in patients with HFpEF?
Yeah, don't know the answer if we should report it or not, because the the cost effectiveness of that, I haven't seen anything yet. So you're talking about a widespread change in reporting, and it may have implications for funding. So I don't know the answer. I think it's a good idea to do it, and I think if you see, but the problem is we haven't really standardized, because every study does it. They use their own criteria. They use number of grams. They look at a different part of the mediastinum. Some people normalize it to body surface area. Some people use these scores like they do with kids. So it hasn't been standardized yet. And so that's probably the greatest reason why it's still a little bit premature for that. But down the road, I think it'll likely be something that's worth reporting. This whole thing started, by the way, because surgeons used to complain all the time about how much fat there was when they tried to do bypasses. That's where it all started. And they all noticed that the bypasses, they didn't do as well. And then it evolved into this follow-up. But what you're going to hear about in the future is not obesity per se. You're going to hear the term toxic adiposity. Mark my words, write it down. The term is going to be toxic adiposity. And it means inflammation. It means cell death. It means abnormal cardiac structure and function. It means heart failure.
And do you think that the differences in, because some people are obese with a lot of pericardial fat, and some are obese without pericardial fat.
Yeah.
And could that explain some of that paradoxical stuff we have with heart failure, and,
Oh.
or just in prognosis?
So now you're talking about the obesity paradox.
Yeah, sure.
So we're going to be here all night. So what Sandeep is telling you is, and this is well recognized, in people with severe chronic disease, people who are obese have a better prognosis than people who are thin. In the general population without severe chronic disease, it's the opposite. Why is that? Well, that's why we call it a paradox. I don't fully understand, but I will say this. When you begin to attenuate, statistically try to attenuate all the things that the people with the chronic diseases have, you attenuate the differences in those factors, it tends to narrow down and sort of whittle away at the association. And I actually just think that it's one of these. I think it's somewhat causal. My own hypothesis, and this is a hypothesis, I'm just shooting out my bum here, but I think what's happening is people with severe chronic diseases that have higher BMIs, it is a marker of their body's ability to withstand that condition, and they are not yet failing. That's my position. So somebody who has the same ejection fraction and the same symptoms, but one of them has a BMI of 29 and one of them has a BMI of 22.
Yeah.
My suggestion is that the person with a BMI of 22 is not tolerating their illness the same way, and they're actually sicker in ways that we have not been able to measure properly. That's my hypothesis. But you might have a better one, because I mean, I'm just blowing smoke here.
I think it's blowing good smoke, so I think we'll Are there any other questions from the audience in the room? I didn't see any more in the chat window. I don't see any more. I tried to gather as many questions as I could from the online and add some more.
They want their dessert.
They want their dessert. Well, they can have their dessert needed too.
Yeah.
So from the one thing I'll tell you about echo, I agree with you 100%. I think we should be doing more exercise echo for diastolic dysfunction. I think there is a will to do it. I think we just haven't really figured out how we're going to coordinate and do it. So
there is interest at the respirologists, by the way. Several respirologists in the heart failure group have expressed a desire to put together a dyspnea pathway for, and I know primary care has asked for that.
Yes.
And that may be something that we could do. And if that's the case, I would definitely see a case to be made for for things like routine PFT testing, routine screening for COPD in people with heart failure, and to establish, a good role for things like CPET and exercise echo.
Great.
Yeah.
Well, thank you.
I think there's an opportunity to look at, for all these programs to look prospectively and do some embedded trials, like, for example, looking at focus. In those cases where I've met it, and the focus comes on, becomes quite widely available, easily.
Yep.
Intelligence.
Yes.
It would be easy to do. I mean, there are all these difficulties, and then I'll come to figure out, does it really make a difference? Taking that back to failure.
Yes.
Looking even by that, just to have suggestion by looking at that.
Yeah, so for people online, what Dean asked was, is there, with a Connect Care coming up, is there a role for doing embedded studies that might involve things like POCUS and other interventions too? And I 100% agree with that. In fact, there are groups both in Calgary and in Edmonton that are currently trying to do that. Justin Ezekowitz was here last week. I missed it. Some of you might have gone to his, he talked about novel trial designs, and they're actively working on that. He wants to do a magnesium study, for example, looking at the utility of measuring magnesium as an embedded study within Connect Care. That one's ready to go now. Like I think it's a great idea personally. There will definitely be embedded trials within Connect Care. It's been proven that it can be done. Other centers have shown that. So the time is right for that. And we're going to do that embedded study with our heart failure pathway anyway. Like that's happening now. In fact, we had a data meeting yesterday. So you called it for sure. Yeah.
And there's going to be a lot better tools within Connect Care for research to actually, have patients in research, know that they're in the research clinical trial. So there's going to be better ways to actually manage research patients within Connect Care. I don't know all the ways that it works, but certainly there will be some better ways to actually do the analysis. And there will be a way to document your POCUS studies. We're going to actually have ways to actually upload your POCUS images, characterized to that patient. So there's going to be lots of additional benefits to having Connect Care coming through. All right, and I see evaluations are being passed around, so please fill out your evaluations. And I'll remind everybody that we have 2 more in this 3-part series, and we'll invite you to those other 2 parts over the next couple of months. Next one is in October, and then another one's in November, and I don't remember the exact dates, but we'll send those along and invite you to those as well. Thank you again, Jonathan.
Thanks for your time,
and
guys.
thank you, AstraZeneca.
Thank you, sir. Should I turn this, or I guess I'll leave you guys to. Okay. I did.